Today, I will talk on computer guidance and patient-specific instrumentation, totally arthroplasty. In this talk, we'll go through some of the studies published in international journals. First on computer-assisted navigation. A multi-center parallel group randomized control trial published in 2018 JBGS. A recent report on a 2-year clinical results from a randomized multi-center control trial by Peterson et al. Compared patient-reported outcomes after computer navigation and conventional total knee replacement. Authors found that computer navigation provided better pain relief and restored better function than conventional methods. However, the authors of this study did not account for variations in the surgical technique, surgeon experience, clinical evaluation procedures, and rehabilitation programs. These can make a difference in the results also. Long-term outcomes of computer navigation. To investigate the longer-term differences in outcomes, Re et al. Performed a meta-analysis of 9 randomized controlled trials that had mean follow-ups of more than 8 years. Computer navigation total knee arthroplasty resulted in a better component alignment outcomes but there were no significant differences in the long-term functional outcomes, revision rates, or incidence of aseptic loosening. The authors called for additional randomized trials involving patients from diverse ethnic groups and countries. The clinical outcome of a computer navigated compared with a conventional total knee replacement in same patients. A prospective randomized double-blind study by Kim et al. Compared 12 years outcomes after conventional total knee replacement and computer navigation in the same patients undergoing bilateral total knee replacement. Clinical function and implant position and survivorship were similar between the groups. The only effect of navigation was a negative one, a higher prevalence of anterior femoral notching. The prevalence of anterior femoral notching was higher in the computer navigated knee arthroplasty group, 5%, than in the conventional knee arthroplasty group, 0.6%. Does computer navigation in the knee replacement improve functional outcomes in younger patients? There is a study on this in a COR 2018, a randomized study. A similarly designed randomized study by Kim et al. Addressed the question of whether computer navigation improved functional outcomes in younger patients. After minimum follow-up 14 years, the authors found no benefit to computer navigation in terms of pain, function, or survivorship. Computer navigated total knee arthroplasty. Rates of adoption and early complications. Coulson et al. Performed a database study to determine whether short-term complication rates were different between computer navigation and a traditional total knee replacement. Authors found no significant difference during 2010 to 2014 in complications, readmission rates, or length of stay between computer navigation and traditional total knee arthroplasty. These findings may be related to the 38% decrease in navigation utilization that the authors noted over the 5 years. Now, I will talk on patient-specific instrumentation. A CT-based patient-specific instrumentation. Patient-specific instrumentation potentially facilitates more accurate implant alignment than the conventional total knee replacement. That was the concept. Zhu et al. Performed a 2-year prospective follow-up study of 40 patients comparing outcomes between PSI and conventional instrumentation. The authors found PSI performed no better than CI with regard to clinical and functional outcomes, mechanical alignment, operative time, blood loss, or length of hospitalization. Their recommendation was routine use of PSI is not recommended in a non-complicated total knee replacement. A randomized trial comparing patient-specific instrumentation to standard instrumentation by White et al. Was published in 2017. they concluded that PSI is simpler, faster, more accurate than conventional instrumentation. The mechanical axis was more commonly restored with the PSI, and coronal alignment outliers were approximately 3 times more common in the CI group. However, this study lacked a power analysis or a sample size calculation, evaluation of clinical function, and assessment of patient satisfaction and sagittal and rotational alignment. Patient specific instrumentation versus conventional knee arthroplasty, a comparative study published in 2017. Predescu et al. Compared 40 total knee replacements that used PSI to 40 that used CI with regard to restoration of the mechanical axis and function. All knees were implanted with the same cruciate substitute implant system. In terms of all functional and clinical outcome measures, there were similar results in each group. The authors therefore don't recommend PSI until and unless further research confirms surgical or economic benefits. Although both technologies have continued to develop, mixed comparative results persist in the literature regarding functional outcomes and restoration of the mechanical axis.